This is a brief introduction to the fellowship by PowerPoint. I wish you could all be here for the interviews. It's a little bit more real in person, but when you're a fellow at Harvard, you're actually an acting instructor at the University of Washington School of Medicine. The fellows have faculty privileges, admitting privileges, surgical privileges, and faculty rights. They're currently set up so that you're primarily working at Harborview, but a little bit of time at one of the UW Medical Center campuses at the VA as well. Currently set up as 3 4-month blocks, although this year we're doing 2-month blocks. That's in evolution. Dr. Benershka does clinical care 4.5 days a week with a weighting toward trauma and post-traumatic reconstruction and some sports injuries. Dr. Bragi has a 5-day-a-week clinical appointment with all areas of foot and ankle, and I have a 3.5-day clinical appointment with some research and academic time. Dr. Ken Chin joined us last year, and he works at the UW main campuses, takes care of the sports injuries, and is the primary location for getting arthroscopy experience on the fellowship. We do have residents on the rotation. There's a PGY3 and a PGY5 who are tasked to cover all of the sites and all of the attendings, but primarily work with Dr. Bragi and I. The PGY3 works with me in the clinic all day along with the fellow, and then on the OR day on Mondays, which is trauma, the PGY3s are in teaching conference and it's only the fellow in the OR. And then on Wednesdays, there are 2 rooms that are staggered and the PGY3 is in one and the fellow's in the other. With Dr. Bragi, he has a fellow and a PGY5, and he has a similar stagger situation when he runs 2 rooms and a similar clinic situation. Dr. Benershka works along with a trauma ACE 2 days a week, but does not have that trauma fellow the other 2.5 days a week. And the time spent with Dr. Chin, which is currently on some Mondays and some Fridays and some Thursdays, is one-on-one time as he has no trainees. Call for the fellowship is 1 week in 5. The call is fairly low key. It's primarily post-op patient calls that come through the transfer center. There are no primary inpatient calls, although if one of our post-op patients ends up in the ED, you'd be called by the resident on call. But there is no emergency room coverage during the fellowship. The city of Seattle is a pretty small town. It's about 770,000 people, although the metropolitan region is a little under 3.5 million. Seattle is home to Microsoft, Amazon, Starbucks, Nordstrom's, Expedia, and formerly home to Boeing. As a result, it has a very international population, with almost 1/3 of the population having been born outside of the US. It's close to trails, skiing, water sports, and compared to the trauma fellows, the foot fellows have plenty of time to do those things. I'd recommend, if you like hiking, to join up with the Trails Association. It's a small donation. It gets you a nice book and a list of all the trails that are within a couple-hour drive and a walk. There is plenty of time to have some fun. Skiing's only about 45 minutes away, although better skiing's about 2 hours away. And Lake Washington is right down the street. When the sun's out, there's no place prettier than Seattle. On the left is the view from Harborview looking south. On the right is a view on the main campus, which is not surprisingly called Rainier Vista. The upper right photo here is a photograph of the women's bathroom at the top of the Columbia Tower. No, I did not take it. My wife took it for me. But it's one of the few bathrooms in the world that overlook mountains and sound through glass walls. The view on the lower right is one that used to be out Harborview's window, but now there are a bunch of high-rise condominiums there, so we can't see it except for a little peekaboo view now. We've had a lot of fellows, somewhere between 80 and 90 since my fellowship in 1987, and they've gone on to do a lot of great things. Currently, this is our list of fellows from 90 to 95. John Anderson's a board member of the AOFAS. John Early is a committee chair. Dr. Bragi is here. Jim Holmes has recently been promoted to the AOFAS board. Andy Sands is the director of AO North America. The fellows who followed them, Chris Coetzee is another past FAS. Mike Aronow is another member of the board. Chris Giovanni is president-elect of the AOFAS. And we have other big contributors like Steve Pinney, who's the editor of Foot Education. Matthew Asal went on to be president of the Swiss Foot and Ankle Society after leaving here. And Hisatiro Niki went on to be the president of the Japanese Foot and Ankle Society after leaving here. Not advancing. Once the fellows leave here, they join the AO Fast chat room list that's hosted by Justin Greisberg at Columbia in New York. Once your name is on there, you can post cases for feedback. You can get feedback from senior or age-matched peers, and you can contribute your knowledge to the group. There are somewhere between 50 to 200 members, as they not only include our fellows, but our fellows, and some great grand fellows. During your fellowship year, we expect you to do some type of research presentation, anything from a retrospective case series to a technique to something a little bit higher grade research. At the end of the year, all of the fellows in the department have a research day in which they present the research talk a week or two before the end of the year. We have a lot of resources for you to work with, a trauma database that goes back to 1992, an ankle arthritis database that goes back to 2005, and a mechanics lab at the VA for select projects. At the mechanics lab, we can do gait studies, typical reflective marker gait analysis with a state-of-the-art motion analysis system. We have the ability to do computer modeling and 3D modeling using a weight-bearing CT scan. This is a not up-to-date simulated weight-bearing CT scan. We actually have a weight-bearing scanner in the lab now. And we can do simulated weight-bearing MRI to have motion models. And Bill Ledoux runs a motion lab that is called a biplanar system that allows you to capture individual bone motion. It's set up so that two orthogonal C-arms can calibrate each bone and get a three-dimensional representation of its motion. It's set up so you walk across a gait lab with a force plate. As your foot goes onto the force plate, it's also captured by the motion detection system. This is the old system that we replaced about a year and a half ago, and our new system's on a little bit of lockdown due to COVID right now, but by the time your class gets here, it'll be open to view and to use. We do a lot of modeling by making CTs of feet and creating bone models. This is an image, fluoro images captured from the biplanar system. You notice that it still has skin markers on it so that it could be calibrated to traditional gait analysis using bone markers and skin markers. We also have a robotic gait simulator that can make a cadaver foot walk or an artificial plastic foot walk. We've used that for a number of projects over the years. And we have two investigators who wrote the software and built the apparatus in the lab. So it's winding up. It's going at about half weight and about 1/4 speed. We're obviously using just a marker rather than a cadaver here, but you can load the individual tendons and alter them from basic biology to simulate a variety of different circumstances. So we wish you could be here interviewing in person, but that's a little bit of an overview of the fellows over the past few years. Thanks for your attention.